So welcome, thank you for having us again. My name is Wouter, and this is my colleague Gerda, and she will introduce herself in a minute. We're going to talk about openEHR, FHIR, and the Dutch CIMs, or healthcare information models, which I will call CIMs the whole time because I use that word, as building blocks in the national health information system. And we're not quite as far policy-wise as Gerda is, I think. But we're making steps, and we'd like to talk about that. So I'm Wouter, I'm an information architect at Nictiz, National Institute for Health in healthcare, in ICT in healthcare. I'm also chair of the openEHR Netherlands affiliate and an openEHR CBP member. Gerda?
My name is Gerda Meijboom. I'm also working at Nictiz, and I'm a lead architect and coordinator of the team of architecture. And I was also a co-author of the National Information Health Vision and Strategy. And Wouter is going to tell something about that later in this presentation. And I have over 15 years experience with exchange of information in healthcare, mostly modeling and specifying for different use cases.
Yeah. So let me first talk you briefly, very briefly, through what Nictiz is doing. We're an organization, a competence center, and we're mainly dealing with healthcare information. We're making information standards, use case specific standards for exchanging healthcare, and also more generic standards like HL7 core profiles for the Netherlands, and also the CIMs, the healthcare information building blocks. We do that because we want to make data available to the patients and to the healthcare providers in a standardized way. We have an extensive network, and our motto will be, it's all about the information, better health through better information. And now, I wanted you to be a little bit interactive, so we had planned to get you stand up and try to do something like this. But unfortunately, I don't have the time right now, so Gerda is going to do the more interactive session, so wait for that, and I'll take you in about 10 minutes through the history in the Netherlands, a little bit of how CIMs came to be and what the current state is. It's going to be quite quickly. First of all, 2 decades ago, there was a fantastic idea to have a federative approach with a national exchange point called the LSP, where we would use HL7 version 3 messages and then create localizations for all the data in the Netherlands, and so that you could get all the data together in one view when you wanted to have it. And then there was a sort of a marketing blunder and a political blunder. We called it the National EHR. And with calling it that, it became understood as this is a national EHR, and we're going to store the data nationally, centrally. And then there were all kinds of privacy questions, and where does the patient get involved, that weren't answered right away from the beginning. Bit of an afterthought, and in 2011, the Senate said, we reject this legal, it was an act, actually, we reject this act, and we're not going there. And since then, a national EHR is sort of a Voldemort, he who cannot be named in the Netherlands. In the same time, in Dutch fashion a little bit, we decided to keep the infrastructure, and it's still running medication orders and stuff lately, and it's even being updated to FHIR in the meantime, but there's not enough funding to do everything there. So we went away from the national approach, and we went into more of a project-based approach, starting to have acceleration programs where different use cases were tried and tested and trying to get them to work. And the focus became more on information exchange, more and more on information exchange in certain use cases. And that, of course, poses some problems, because then you have to try to get those use cases to work together. That hasn't worked out completely, and probably in every country you can make these kind of pictures where there are a lot of different ways to exchange information, different ways, pathways and standards used to get there. So that was not ideal. Luckily, and I think it's luckily right now, there was a project called Registration at the Source. And they started when the first big EHRs went live in hospitals, in university hospitals, mainly Chipsoft and Epic in our case right now, and Nexus as well a little bit. And university hospitals, together with Nictiz and other parties, said, yeah, we have to have some sort of building blocks for information. And we're going to call them, let me see, yeah, ZIPs. So the ZIPs were born. That took a little bit of that took a while, and the first products that came out were standardized ZIPs, which you can find on zips.nl. So if you want to look that up, they are all publicly available in English. And we started to make the first version of an IPS. Of course, a Dutch version of the IPS is not ideal. We tend to do that sometimes, but we'll have to try to convert that back at some point. And that became public. So yeah, that's what I wanted to do. This is a zip, and you can see this is more or less the same thing as an archetype. There's a central concept, like blood pressure right here, and we define what data elements should be considered for reuse in the healthcare information space. It's a standard also based on a standard called 13972, which deals with clinical information models. And the difference with archetypes are small but somewhat relevant. They're a little bit more conceptual, so they're even more thought from the caregiver's perspective. And there's the 80% rule, and this is actually important. So we're only defining 80% of the data elements that probably every caregiver wants to use in their care settings. We define terminologies inside them, so they are specific for the Netherlands, and they are implementation agnostics. And we use them to create information standards like an e-transfer standard for transferring patients from secondary care to primary care or back. Yes. Yeah, then a little bit, of course, this is the ZIPS way, and then some people started to think also, maybe we can do things in another way. This is also typically Netherlands. If top-down doesn't work, we start bottom-up, developing also some other things. And this is openEHR. I borrowed these from the masterclass openEHR from Jan, these pictures, just to know them. We started in 2019 with openEHR Netherlands, just with Sebastian, he was here, and Joost, but he's presenting in another, not Joost, but no, Marcel was presenting in another room, and Joost and Anne just have joined us in that period. And that was just to spread the knowledge of openEHR, our first thing, and also try to see how we can align with national and international standards better, specifically national standards. Well, the front runners, Code 24 since 2010 already, using openEHR, and NADAP is transitioning, well, a good couple of years already to openEHR and changing more and more of their system into openEHR. Those two have been front runners for a long time, but really more recently, in the last few years, we see really nice and interesting things happening in the south of Holland. That's also why the map went up a little bit, because they're all the way down there. Very good. Enthusiastic people. And what they're doing is actually really interesting. They're having a federative approach with already Code 24, NADAP systems, also Better and openEHR already going into that, Better and Vita Group are going into that space. And they're trying to make a federative system for both primary and secondary care in the region. So probably more about that in later meetings, I suppose. And then there's all kind of smaller projects going on, which are really interesting, and I just want to mention, I think the side project is really interesting because what they're doing is they're starting really small, but they're using an existing low-code platform, which they integrate with openEHR. And it seems that, well, this is going in the right direction. Also, we have School for Applied Sciences who's interested, and also interesting outbreak management. Well, big topic after 2020-22. They are looking into openEHR as well. So now back to the current situation. This is what's always was going on. Current situation in the Netherlands for the healthcare information system. And I realized later on when we were doing this presentation, this should probably be going from health to care, like was said and mentioned in some of the other presentations, because that's the goal. Also do prevention in here. We have a bunch of legislations, of course, European health data space, but almost everybody has to deal with that in this room. And we have a specialized law on data exchange that's being implemented. Not going to talk a little bit about that. Then we have some policies. Integral care agreement, the ISA is interesting because it's an agreement with government, caregivers and organizations around that where health IT should go. So it's from that perspective. And based on that, and I'm going to talk a little bit about that, there's a national vision on the health or care information system, the global of the national system for that. And this is a one-page summary, which is really nice, but they've never translated it. It's something, so I'll do that for you. It's an idea that we have this completed in 2035, which I thought is nice because it's at least a little bit longer than usually in politics, a little bit of a longer vision. And the main things, the main foundations are that we want to work on data availability, so getting the data available where it needs and where it goes, stepping away a little bit from information exchange. Having a layer of trust between caregivers and the patients, and so that they can maybe also work on the same care records at the same time. And there must be some direction, some guidance from top down, because otherwise this is not going to work. And then there are 4 guiding principles, of which one of them is probably, well, there's an echo here in the room, and that's data is separated from function. And where I think it's getting really nice are those perspectives that they put there. And I picked out the 2 that are, I think, or the 4 that are actually, I think, are most important. We're going away from a single care record for a process inside a healthcare organization to a people-oriented person record, longitudinal record. That's the idea. And we're not going to do that with distributed records, but we're going to try to create one virtual, probably federated record per patient. That takes me to one of my last slides, and then I'll give Gerda the room. And that is, this is the first directive actually sort of that came out, an advice that the ministry said we have to implement this. And this is a compromise, because we said we have to standardize all these exchange formats and try to come up with one. And so we came up with 2. We have publication of the CIMs, which say this is the clinical information models that are now valid, and we have 2 of those. One is named 2017, coming out in 2017, and one is the 2020 publications. And because they're both running now sort of in parallel and already projects were started, they decided that the 2017 should be with HL7 FHIR S2E3 and the 2020 publication with HL7 FHIR R4. And those are the 2 that should be the main ones in a couple of years. The first thing that has to happen is that there have to be migration plans, and the migration plans are made per sector in the Netherlands to get them going. And that's the first step. In the end of 2025, those migration plans should be ready, and then we have to execute them. And with all this and all this background, I'm going to now give Gerda the floor to talk a little bit about how, well, openEHR is also going to fit into this story, yes, and how CIMs and openEHR work together.
Yeah, thank you, Wouter. Wouter talked a lot about the history and the evolution in the Netherlands. I will talk more about the CIMs and what was going on there. 2 years ago, we published a report which describes all kinds of issues we have with the CIMs. And we have a model, we call it the implementation model. And you see different steps from 1 to 8, from at one hand the providing system and at the right side the receiving or retrieving system. And it starts with the registration, the storage of data extraction, conversion, etc. Till the reuse by another user of the information. And yeah, it's the data flow, you could say, through different systems with the exchange in the middle over an infrastructure. And in this report, different issues were described. Most issues were about one of these 8 steps. So it could be that the user interface wasn't correct. For example, we described in the CIMs which values you should register, but in the screens of the healthcare provider, they had another drop-down list with different options. Or maybe there was an issue with the CIMs. They call it with the CIMs, but they said on the screen of the end user, there was data missing. But what was the problem? It could be a technical problem on the way, on all those steps, but it could also be that the data wasn't registered or that it was not presented in the system. So there were a lot of issues, and people said the CIMs are not working, but it depends on where you look at. The modeling of the CIMs, so the information model, was just a small problem. There were a lot of other issues. And we focused these issues, we try to solve these issues in a program in the Netherlands, but my presentation is only focusing on the CIMs. The CIMs itself, the modeling of the CIMs. And we are using the CIMs now for over 13 years. And we learned a lot in this period. And I think some of these will be recognizable for the modeling of others in other standards as well. The modeling of different concepts is very time consuming. You have to agree to get an agreement with a lot of different people and actors in the healthcare system for each model. The expertise of different people is rarely available. Healthcare providers are busy, so maybe you can have them on board in the evening, but then the modelers are not working. So that's also difficult. And we have some architectural issues. How big should these CIMs be? And should there be generic CIMs or more specific? Should we have both? These kinds of issues we faced the last couple of years. And sometimes we have decided how to do it, and sometimes it's still a discussion. The CIMs are based on an ISO standard, as Wouter told, the ISO 13972. And that gives a lot of freedom. We see that now in Europe, in the development of the European Health Data Space, in the project Extended EHR. They are using the same ISO standard, but when we look what they made of it, what kind of CIMs they made, they are different from ours. So using a standard is not always a guarantee to success or to having the same models. So a lot of issues with the clinical information models. And we are running a program in the Netherlands to solve these issues. One of the... Moet ik die kant op wijzen? Why is it not working anymore? Oh, I think all the bullets are now one by one.
Oh yeah, there it is.
Oh. Oh, that was it. Yeah, there's one major question we have to answer. What are the CIMs? What's the position of the CIMs? How we want to use it? How are they related to the other standards in the model? And we distinguish two axes where we talk about. And there's a green and a purple one. And the green one, we distinguish the world of healthcare and the world of ICT. I think most people will recognize that. Information models are between those two worlds. They are connecting those two worlds. But we also distinguish data processing and the exchange of data. And we also say data processing and the exchange of data needs their own policies and they need their own standards because these are different worlds as well. And we have to make a distinction about that. Wouter promised some interaction, so that's coming now. We have a statement, and that is saying data processing and data exchange have their own policies and standards. And I would like you to ask to stand up if you agree with this, and sit down if you don't agree.
This is the interactive part. So no, right now nobody agrees with this. Watch out, I'm coming into the room to ask you why you don't agree with this, so make up your mind.
You, Wouter,
yeah.
Can you walk to... What's the difference in the answer?
I think they
should.
Yeah.
Should.
But they are not.
Yeah, we're talking about the future here, so I think you should say should.
Okay, sure.
Okay, so nobody agrees with that statement. That's the... All right, okay. Luckily.
Yeah, if you want interaction or you want to move a bit, then you stand up.
Yeah, I'll just pick somebody to talk about that maybe. First, you agree, sir?
Yes. It depends. The data at rest obviously has to rest for a lot longer than the data that's moving. I mean, the fact that an exchange of information has happened, that predicates the creation of records at the other end. It's a kind of a handover, isn't it? Whereas the data at the rest there, that has longevity requirements that are much different from the messages or the exchanges or the API access of those things.
Okay, yeah, I agree with that. Let me find somebody who doesn't agree. Let me move a little bit back here, because in the back room it's always easy to not. Who would like to say something about who doesn't agree to that? Yeah, there we go, Celia. Yeah, of course. Expected that. Here you go.
Well, I agree that they do, but I don't agree that they should. One thing, I think it's perfectly possible to design models, standards that cater to the differing requirements between exchange and data processing. And also, when you have different or own standards for each of these things that need to be closely connected to each other, you have a mapping hell, which does not scale, in my opinion.
Yeah, I think I would like to have everybody else talk a little bit more about, but I think you have to go to your second statement if I look at the time.
Yeah. Yeah, you said good things, I think. We agree, of course, with this statement. It should be the case. Because at the side of processing, you only have one actor. He can decide everything, but when you are exchanging information, you have to make an agreement, or you have to talk to each other how you will translate the data. And when you look at, for example, also terminology, if you are registering information, you can use your own terminology. But when you are exchanging data to another actor, you have to say which terminology you are going to use. And also in data processing, you should be consistent in your data, and your data should be persistent in the system. And when you are exchanging the data, it's only a snapshot in time. So you make, it's just a snapshot of the data you have in your system. That's why we think we have to make this distinction. But as there was said in the back of the room as well, you need something to connect these two sides. And we think there should be an information model in the middle, because it's the same information. So that you should model the information in the same way. Else you will have a large problem with the translation and with the mapping.
We're running out of time a little bit.
What we are saying, data processing should be done with openEHR preferably, and the exchange of data we should use FHIR. Will we have time for another?
No, I don't think so. I don't think so. I don't think so. We have to leave this to the discussion later on.
We had a little discussion planned for this statement, if the CIMs should be internationally standardized. Maybe we are in the belly of the beast here, because openEHR with their archetypes, it is an international model. But we would like to hear your experience, but maybe we can do that after the presentation in the pods.
In the break.
In the next break. I said something about this. So the CIMs are in the middle, and that's what we need. And important for us is also the cooperation between different standards, because that makes the standards even stronger. They have their own purpose, they have their own goals and strengths, and they should work together. In the Netherlands, we do that. For example, with a cooperation between Nictiz and openEHR Netherlands, that's on the way to be signed by both management and bestuur.
Yeah, board.
Board, thank you. We have at the moment a public consultation of our vision around the CIMs. And what we see in the EU, they are working on the CIMs as well, and we hope they will choose an international standard to build on in the European health data space. And yesterday we heard something about cooperation between openEHR and HL7. That's very nice, but it's very important, we think, and that's the message we want to close with. We should work on an information model that can be shared by everyone, and internationally, probably that will be a huge step. But it's very important to have the same information model to be interoperable. And I hope we can work on that the coming time, and also that HL7 and openEHR will work on that. So then we can minimize mapping efforts, and we can share the scarce resources we have for modeling and healthcare professionals.
Thank you.
Thank you.
Thank you.